So students, now going with the specific antimicrobials, the first disease that we complete or start with is tuberculosis. Right now, tuberculosis is caused by Mycobacterium tuberculosis. Okay, now this mycobacterium also causes, there is one called as Mycobacterium leprae, which causes leprosy. So these diseases are usually linked. Then there are some atypical mycobacteria which are seen to cause pneumonia and some infections in immunocompromised patients. Okay, now what are the drugs which are used for the treatment of tuberculosis? So let us see the first line drugs first. I'll say the first line drugs. The first line drugs are isoniazid, rifampicin, then pyrazinamide and ethambutol. Okay, then supplementary drugs or the second line drugs are streptomycin. These are not second line, these are supplementary additional drugs. Then rifabutin and rifapentin. Okay, and then the second line. What are the second line drugs? Second line drugs are PAS, thioacetazone, ethionamide, cycloserine, kanamycin, capreomycin, amikacin. Then we have ofloxacin and levofloxacin, moxifloxacin, linezolid and clarithromycin. So these are the drugs which actually cause which are the second line drugs. Okay, now let's come to isoniazid and let's take every drug one by one. Now isoniazid is a prodrug, right? It is activated by catalase peroxidase. Now this active metabolite, it inhibits the enzyme that is called as keto-enol reductase. Okay, now this enzyme keto-enol reductase is required for mycolic acid synthesis, which is an integral part of Mycobacterium tuberculosis cell wall. So this is the main mechanism of action of isoniazid, and this is how isoniazid acts in the tuberculosis patients. Now this important points related to it. It is bacteriostatic, right? It acts on rapidly multiplying TB organism. It is effective on intra as well as extra cellular mycobacteria, right? Action is most marked on the rapidly multiplying bacteria. It has got maximum distribution and maximum CSF penetration. Then it is taken orally and it undergoes acetylation. That is the metabolism, and this acetylation is, as you all know, it is genetically controlled, right? Then we have fast acetylators which require higher dose, and we have slow acetylators which basically undergo toxicity, right? Then this is an essential component of multi-drug therapy. This is the drug of choice for prophylaxis of tuberculosis and treatment of latent infection. Okay, then it causes peripheral neuritis. This is treated by pyridoxine. Okay, some more details about isoniazid, that it is hepatotoxic and causes hemolysis in G6PD deficient patients. Then it also inhibits MAO-A, so it can cause cheese reaction. Okay, and then a lot of other side effects like rash, fever, anemia, optic neuritis, seizures, lupus, psychosis can be seen. The next drug in tuberculosis is rifampicin. Now this rifampicin is a derivative of rifamycin, and other derivatives are rifabutin and rifapentin. Okay, then it is bactericidal. It acts on both dividing and non-dividing bacteria. Then it is it inhibits DNA dependent RNA polymerase. Okay, this is the drug which is acting on the DNA. So this we had discussed last in the drugs which are inhibiting the DNA, that it undergoes enterohepatic circulation, and it basically interferes with the OCP absorption and causes pregnancy, because it causes failure of OCPs. So why this rifampicin should be, if a patient who is pregnant, who wants to become pregnant, or who doesn't want to become pregnant and is on OCPs and is then started with ATT, then can develop pregnancy also. Another important feature is it develops orange discoloration of urine. It can cause orange staining of contact lenses. Then it is eliminated because it is undergoing enterohepatic circulation, so it is eliminated in feces and used in renal dysfunction. Okay, it has to be given empty stomach because it interferes, the absorption is interfered with food. It also penetrates blood-brain barrier, so, and placenta also. It penetrates placenta also. It is equally effective against intra as well as extra cellular bacteria, right? Then it is also used in leprosy, most effective drug and fastest acting drug, right? It can be used prophylactically in meningococci and staphylococci infections. Then it basically is hepatotoxic. Toxicities might also causes flu-like syndrome. Remember this, and it causes skin rash. Okay. Then hepatotoxicity might usually present as hyperbilirubinemia without SGPT elevation. Okay. Then another very important thing about rifampicin, it is an inducer of enzymes. Okay. So this drug can have a lot of interactions with the anticonvulsants or OCPs, as I told you, oral anticoagulants and HIV drugs also. Rifabutin has little chances of drug interaction. Okay. Then PAS delays the absorption. Patients on warfarin should shift to heparin or low molecular weight heparin. Okay. Then there is another analog, rifamycin. Rifamycin is recently approved for treatment of traveler's diarrhea. Okay. So all these points were about rifampicin. Coming to the next drug in antitubercular drugs, that is pyrazinamide. Now pyrazinamide is a weakly bactericidal drug. It is most active on slowly replicating bacteria and in the acidic media, right? So that means it acts on intracellular and at site of inflammation also, right? So it has got the best sterilizing activity. Next here, it is then effective against intracellular mycobacteria. Then it causes non-gouty arthralgia, hyperuricemia also occurs. It causes hepatic dysfunction, porphyria, and also photosensitivity, right? So these are the points against pyrazinamide. Next we come to ethambutol. So ethambutol is a bacteriostatic drug. Then it inhibits, it's a metabolic inhibitor, it inhibits the arabinosyl transferase. It is distributed except throughout the body except CSF, it doesn't go in the brain. Then it causes visual disturbance. What is that? Basically optic neuritis like thing. So there's a reduced visual acuity and there's a central scotoma and loss of ability to see green and less commonly red. Okay? It is because, why does it happen? Because it affects the amacrine and bipolar cells of retina. So this drug is contraindicated in children. Then it also causes hyperuricemia and peripheral neuritis, and then it requires dose adjustment in renal failure. The next drug and the last drug usually in the first line drugs is streptomycin. Now streptomycin we have studied in the aminoglycosides also. So this is basically a tuberculocidal drug. It is an aminoglycoside, right? It is not absorbed orally and given by iron route. Then its half-life is prolonged, active against extracellular bacteria. It is not hepatotoxic, but it is contraindicated in pregnancy. Okay, so these are the various first line agents that we usually study. Some other drugs now in this is thioacetazone. Now thioacetazone is a tuberculostatic drug. Adverse effects में आते हैं इसके hepatitis, bone marrow suppression and Stevens-Johnson syndrome, right? So it is not used in HIV positive patients due to risk of severe hypersensitivity. ठीक है? Then it is not used in intermittent regimen. Then there is a substance PAS. It is similar to sulfonamides and it is basically bacteriostatic, right? Then PAS के बाद एक दूसरी drug आती है ethionamide. Ethionamide is also a static drug and it can result in optic neuritis and hypothyroidism. This ethionamide can be used in leprosy also, right? Then we have cycloserine. Cycloserine is a cell wall synthesis inhibitor and it causes neuropsychiatric adverse effects. Then we have kanamycin and amikacin. These are injectable aminoglycosides used in the treatment of MDR-TB. Okay. Then we have capreomycin. This is an injectable polypeptide. It can cause ototoxicity, it can cause nephrotoxicity, can cause hypokalemia, and it also causes hypomagnesemia, right? Then other drugs that we have are fluoroquinolones. इनमें आते हैं ofloxacin, then moxifloxacin, then levofloxacin. Then there are newer macrolides like azithromycin and clarithromycin. They are also used mostly used in atypical mycobacteria, right? Then we have rifabutin. Now rifabutin is more effective than rifampicin against Mycobacterium avium complex, right? It is also preferred in patients on HIV drugs. Okay? After that, this drug can also cause pseudo jaundice. Okay? So rifampicin is more effective against MSC, longer acting होती है, less effective in TB as compared to rifampicin, and no dose adjustment is required in liver disease. Okay. Then similar to rifabutin, there's another drug which is called as rifapentin. Rifapentin is more lipophilic and it is longer acting, right? So this is not approved in HIV patients, right? Let us see the newer antitubercular drugs now. So newer anti or ICT drugs are, I call it as ICT because in my MBBS days we were taught as anti-COX treatment. So it was tuberculosis was called as KOCH COX. So now the newer ICT drugs are bedaquiline. This is an inhibitor of mycobacterial ATP synthase. Okay, it causes QT prolongation and it is given as a part of multi-drug therapy in adults with MDR-TB. Okay, the second drug that we have is delamanid. Now delamanid is a nitroimidazole derivative. It inhibits mycolic acid synthesis. Okay, then it is used in XDR tuberculosis, XDR-TB. It also causes QT prolongation. Okay, next drug is pretomanid. This is another nitroimidazole. It acts by the same mechanism. Then it is approved in combination of bedaquiline plus linezolid. So this is called as BPAL therapy. Okay, bedaquiline, pretomanid and linezolid. Okay, now this is used for MDR and XDR-TB both. Adverse effect includes QT prolongation and bone marrow suppression. Okay, now let's come to the treatment part of tuberculosis. So treatment of tuberculosis, the RNTCP program, that is revised National Tuberculosis Control Program, is now called as NTEP, that is National Tuberculosis Elimination Program. Now isme the patients are divided into two categories. Category 1 is patients who are new, category 2 is patients which are old, and category 4 are patients who are drug resistant. Okay, so these are the under RNTCP these were the guidelines, category 1, 2 and 4. NTEP doesn't use these categories. Okay, now all patients of let us see the treatment for drug sensitive TB. Now drug sensitive TB में all patients, whether they are category 1 or they are category 2, they are treated with 6 months of therapy, in which there is 2 months of HRZE and plus 4 months of HRE. So this is the therapy for drug sensitive TB, including new as well as old patients. Okay, the next is drug resistant TB. Now drug resistant TB में we have isoniazid resistant. First, let us see. So according to latest guideline, if a patient is isoniazid resistant, then he is treated with a 6 months course, okay, of 4 drugs. Now what are those 4 drugs? R, Z, E and levoflox. So rifampicin, pyrazinamide, ethambutol and levofloxacin. Okay, if this is an MDR TB or rifampicin resistant, so when the person is resistant to both isoniazid and rifampicin, then it is called as MDR TB. Okay, now what are the regimen for MDR TB? For MDR TB we have 3 regimen. Okay, let us see the regimen one by one in detail. So the first regimen is called as shorter regimen. Okay, now shorter regimen containing bedaquiline. Now the patients of MDR TB possessing following criteria are candidates for this regimen. First of all, resistance to fluoroquinolone is excluded, so they are not resistant to fluoroquinolone. Then they are not exposed to second line drugs. Okay, not extensive TB, no severe extra pulmonary TB, no pregnancy, and age more than 6 years. So under all these patients, they are treated for 9 to 11 months. Right, now intensive phase or IP phase consists of 4 months, and it can be extended to 6 months if culture is positive at the end of 4 months, and the continuation phase is of 5 months. Okay? Now IP, that is intensive phase, may the patient is using high dose isoniazid, then pyrazinamide, ethambutol, levoflox, okay, clofazimine and ethionamide. Now in the continuation phase, all drugs except isoniazid and ethionamide. Okay, all drugs are given, and apart from this IPCP, bedaquiline is given for first 6 months. Okay, so this is the shorter regimen containing bedaquiline. Isme see injectables not given. Okay, then levoflox is preferred over moxiflox. So if I write it as this, so in short 6 months के लिए bedaquiline plus 4 to 6 months के लिए high dose isoniazid, pyrazinamide, ethambutol, levofloxacin, clofazimine, ethionamide, plus for 5 months pyrazinamide, ethambutol, levofloxacin, clofazimine. Right. So this is the therapy for the MDR TB shorter regimen containing bedaquiline. Now coming to the next regimen, that is longer regimen for MDR or rifampicin resistant TB. Now patients who are not candidates for the shorter regimen are given this longer regimen. Now isme the drugs are divided into 3 groups as follows. What are those 3 groups? Let's see them one by one. First is BPAL regimen. That is, I told you, that is the BPAL regimen was the where is it from? Newer drugs now. Yes, so that is bedaquiline, pretomanid and linezolid. So BPAL regimen. Now it is recommended for patients who are resistant to fluoroquinolones, then who are not exposed to bedaquiline or linezolid. So what is this regimen? This is 6 to 9 months bedaquiline plus pretomanid plus linezolid. This is the BPAL regimen. Okay. Now let's come to the preventive regimen. That is for prevention of TB. Okay, so prevention of TB में the close contacts of the patient active drug sensitive tuberculosis, they are given 6 months of isoniazid daily. Okay, empty stomach, and it is safe in HIV. Another therapy is 3 months of 2 drugs, isoniazid and rifampicin. Okay, this is safe but not suitable for PLHIV. देन तो ये तो हुआ 6 मंथ्स के लिए आइसोनियाजिड उनको दी जाए, दूसरी रेजिमेन है 6 months के लिए आइसोनियाजिड प्लस रिफापेंटिन दी जाए. That this was close contacts of drug sensitive. Now close contacts of drug resistant. अगर drug resistant TB है तो आप दोगे 6 months के लिए आइसोनियाजिड. Okay, if the patient is in contact with isoniazid sensitive, ठीक है, TB, and you will give rifampicin for 4 months daily if patient is rifampicin sensitive. And the third thing is you will give levoflox for 6 months if patient is MDR TB but levoflox sensitive. Okay, so please remember this. If isoniazid sensitive, give 6 months of isoniazid. If rifampicin sensitive, give 4 months of rifampicin. If MDR TB hai but sensitive to levoflox, give 6 months of levofloxacin. So this is the regimen for TB prevention. Then next, the TB treatment may be extended to 18 to 20 months also, right? Then treatment is usually continued for 15 to 17 months after culture conversion. ठीक है. Another thing, injectable drugs are avoided. Then ethionamide or PAS to be included. If bedaquiline, linezolid, clofazimine is not used. Okay, so this was another longer MDR regimen. Then we come to the atypical mycobacterial infection. Now atypical mycobacterial infection में clarithromycin or azithromycin is recommended for prophylaxis of Mycobacterium avium complex in patients with CD4 count less than 50 microliter. Then treatment of Mycobacterium avium complex requires REC regimen. What is this REC regimen? This is rifabutin plus ethambutol plus clarithromycin, right? Due to its long half-life, azithromycin is used as once weekly dose. Okay, so this was about the atypical mycobacterial infection. The next the next disease that we have to study about is leprosy. Coming to the treatment of leprosy now. So leprosy में जो drugs use होती हैं, the drugs which are used are rifampicin, then dapsone, then clofazimine, ethionamide, ofloxacin, minocycline, and clarithromycin. Okay, so these are the medicines which we use in leprosy. Now let's see the drug dapsone. Now what is dapsone? Dapsone is basically a static drug. It is related to sulfonamides. It belongs to the sulfonamide group and has the same mechanism of action, that is, it inhibits the formation of folic acid. Now the second thing, it is metabolized by acetylation, just like sulfonamides are metabolized, right? And it undergoes enterohepatic circulation. Then it causes side effects में GI distress and fever, rash, hematuria, methemoglobinemia, and hemolysis, right? All the same type of side effects. Hemolytic anemia is the most common. What? Hemolytic anemia is the most common side effect of dapsone, right? Now it can also result in DDS syndrome, which is sulfone syndrome, that is called as infectious mononucleosis like syndrome. Okay, now इसमें आती है एसिडैप्सोन. It is a repository form of dapsone, and here the single intramuscular injection is effective for 3 months. Dapsone is also the alternative drug for treatment of pneumocystis jirovecii pneumonia in AIDS patient. Okay, it is, I'll write it here, it is the drug of choice for dermatitis herpetiformis. Okay, so this is the detail about dapsone. Let's go to the next drug. The next drug is clofazimine. Now clofazimine is a dye, basically it is a dye, and it has got a leprostatic and anti-inflammatory activity, right? It interferes with GI irritation, then ichthyosis of skin and discoloration of skin, right? It is used for lepra reaction also because of its anti-inflammatory action. Then next we have rifampicin. Now rifampicin is a cidal drug and most effective drug in leprosy. It is used to prevent development of resistance to to dapsone. This is the most important thing, that it prevents the development of resistance to dapsone. Then other drugs. In this we have ethionamide, then ofloxacin, pafloxacin, starfloxacin, but ciproflox is not active against Mycobacterium leprae. Now, what are the types of leprosy? So leprosy के दो types होते हैं. One is paucibacillary and one is multibacillary. Paucibacillary, in which less than 5 lesions, and it includes TT, BT and indeterminate leprosy. Multibacillary is more than 5 lesions, smear positive cases, and it includes BB, BL and LL leprosy. Okay. Now, what are the WHO guidelines for the treatment? So, as per the latest guidelines, both multibacillary and paucibacillary to be treated with 3 drugs. Okay, and that is 600 milligram rifampicin plus 300 milligram clofazimine, that is once monthly, plus 100 milligram dapsone plus 50 milligram clofazimine once daily, right? They are given for 12 months in multibacillary and for 6 months in paucibacillary leprosy. So please remember this treatment, that both multibacillary, paucibacillary में 3 drug treatment, rifampicin, clofazimine and dapsone is given for 12 months in multi, for 6 months in pauci. Clofazimine is given once monthly also and daily also, right? So this is basically drug sensitive. Then for drug resistant leprosy is treated for 2 years. For first 6 months 3 drugs are used, right? For next 18 months 2 drugs are used. So this is how that the treatment is given. Now, previously paucibacillary leprosy was treated with 2 drugs, clofazimine was not used. Now paucibacillary is also treated with 3 drugs. So this is the treatment guidelines for leprosy. Next we take the next category that we take is antifungal drugs. Okay.